Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening. At first, I thank all of you for being here. Special thanks for Dr. Abdul Hadi Bina for collecting us with each other and give us the opportunity to be in such a beautiful place here in Jeddah with the privilege of all doctors and physicians here from different scopes. Thanks for our sponsors that with their support we can continue to spread the word around the KSA and the Middle East. Thank you all. Thank you, Professor Kim, for being here and support us. You are one of my best teachers that I learn always from you. I am honored that you are one of my references for my book, and thank you for being here. At first, today's topic will be as a resonance for the doctor's topic. We all talk about the similar issue about insulin resistance. From my practice in our clinic, I've always refused to take kidney patients, especially patients with chronic kidney disease or acute kidney injury, because as we all know or always know, that doing a low carbohydrate diet is harmful for the kidney because of the high amount of protein that it's in. Another issue that when you go to starvation, the kidney has to support the liver in the glyconeogenesis. So by the beginning of the ketosis, after 1 week, the kidney will provide 40% of all glucose support to support the kidney itself and the body. So how can I, Ahmad Samara, to practice this with my patients and do a ketogenic diet for a patient that has already compromised kidney? The story begins with a dietitian in our clinic that has her aunt, and her aunt has a chronic kidney disease. So her aunt wants to do to lose weight with us, and I refused. After several months, he came again, and she asked. So I told her that I have never done it before, and we will begin. So we began a protocol that resonates with the recommendation from the dietitian, our literature, to reduce phosphorus and potassium as well as reducing protein. And add for it another thing of reducing purine, to reduce uric acid, eliminating fructose to eliminate uric acid synthesizing in the kidney, as well as, of course, reducing carbohydrates. At first, I would like to represent myself. I am your brother, Ahmad Samara, a clinical dietitian and low-carb nutrition. I have a book which is called Keto Roadmap. I have diploma in general personal training sports. So I do reach 200 beat per minute when I do my exercise by bike. Okay, so I am 20 years old like this. Okay, I was a structural engineer. Before I have converted to be in nutrition. When I had continued my bachelor degree in nutrition before the beginning of the corona. And we will talk about the protocol of ECMIC, ECMD, which is Energy Conservative Metabolic Kidney Diet. We will talk about the understanding of the progression of diabetic nephropathy, the side effect of mechanical stretch on the glomerulus and its relation to the high blood sugar, discuss the best diet for diabetics with kidney disease, the benefits of being in starvation and ketosis, okay, when doing the protocol, the ECMIC-D protocol. Can we reverse kidney disease? And what is the case studies in our clinic? diabetes is the most, it's the best, or the main cause of being in chronic kidney disease is diabetes, as 45% of all diabetics will have issues of chronic kidney disease. When we are talking about type 1 diabetics, this ratio increases to more than 70% of all. They will have developed 70%, they will develop chronic kidney disease within 15 years. If the blood sugar for them more than 180, which is the renal threshold for the glucose absorption, this ratio will increase more than 70. If we want to talk about the diabetic nephropathy, the diabetic nephropathy begins with the increase of glucose, carbohydrate, as well as fructose and vegetable oil consumption. It will lead to high insulin resistance in the liver, which will induce fat accumulation in the liver, leading to fatty liver. The increase of fat in the liver, will increase the amount of glucose circulating in the blood, which will increase insulin, as well as will increase TSH and tyrosine secretion. The fatty liver and high estrogen caused by a lot of accumulation of fat in the fat cells, as well as the high level of thyroxine, will induce the renin system, the angiotensin renin system, which will indeed increase the blood pressure. The increase in blood pressure, as well as the increase of reabsorption of glucose and sodium within it, as well as the absorption of sodium supported by aldosterone, will increase the renal cortex hypertension in the cortex. This will increase the mechanical tension within the glomerulus itself, supported by the increase of blood pressure that is needed to flow the blood within the glomerulus for filtration. As we can see at the picture in the right, this is the kidneys of two mouses in a trial. The first one is a normal mouse at the top, and the second one is a diabetic mouse, is a type 1 diabetic mouse. Mm-hmm. So the increase in pressure caused in the cortex lead to an increase in the kidney size. So if the kidney has a lot of pressure, what will be the pressure inside the glomerulus in order to pump the blood through it? The increase, Here we can see the chart that I have drawn for the diabetic nephropathy at first the refined carbohydrate cause an increase in blood sugar. The blood sugar increase will increase fatty liver. The fatty liver can cause a lot of accumulation of fat, as well as increase in angiotensin. The angiotensin will increase the blood pressure. The blood pressure will increase the glomerulus hypertension and hydrostatic tension and will increase the mechanical tension in the glomerulus. On the other hand, this tension in the glomerulus will increase the production of extracellular matrix component in the mesangial cells, and supported by the upregulating of GLUT1 mesangial cells in the mesangial cells. So, what happens inside the glomerulus at first? When we have a mechanical tension in the glomerulus, the glomerular capillary hypertension causes the changes in the glomerulocyte, in the mesangial cell and podocytes, and cause hypertrophy for the podocytes and apoptosis in it, as well as interstitial fibers inside the mesangial cells. The mesangial cells morphology is changed from the normal satellite to a strap-like appearance perpendicular to the stress inside the glomerulus. The mechanical stretch upregulate increase the glucose transport GLUT1 by 80%, which support more production of the interstitial matrix. Mechanical stretch induce extracellular matrix as well as inflammatory pathways. Mechanical stretch stimulate the production of renin and increase the activity of the angiotensin renin system and increase the blood pressure. What happens to the podocytes? The podocytes بس لغير الأطباء البودوسايتس هي اللي بتربط الجلوميريولس مع بعض، يعني احنا عندنا we have the glomerulus جواتها نسيج اسمه المسنجيال سيل، هذا بيمسك الجلوميريولس مع بعض حتى لو هي تنفجر بربطها مع بعض، هي عباره عن كره والبودوسايتس بتكون محيطه فيها. هلا تخيلوا انتم عمالكم تضغطوا a lot of water inside a balloon, it will explode. So when we have a lot of pressure، عندنا ضغط عالي جوا الكلى، we have a lot of pressure جوا الجلوميريولس اللي هو الفلتر تبع الكلى، بصير زي اللي بدها تنفجر، فبده يتغير شغلتين، البارير اللي هو الممبرين which has the podocyte will be less stiff, will be stiff and less flexible, as well the interstitial matrix inside will change its direction، حتغير حالها بحيث تقاوم الستريس حتى ما تنفجر. The increase in mechanical tension podocytes reduce the podocyte cell proliferation and reduce the cell adhesion and basal membrane. This mechanical tension increases the ACE, which the ACE is a product from the lung that increases blood pressure, and reduce the ACE2, which reduces the inflammation and which reduces inflammation. So the ACE over ACE2 ratio increased by mechanical tension will cause inflammation, hypertension, vasoconstriction, as well as cell proliferation and fibrosis. So we now know that there's a problem in hypertension and in the glomerulus. What is the diet to follow for kidney disease and diabetes? So it's clear that we have to that high glucose levels will as well as glomerulus high hydrostatic pressure cause deterioration of kidney structure. So it's crucial to cut carbohydrates, managing and normalizing blood sugar while controlling blood pressure within the normal range. Yes, by cutting carbohydrates, we'll eat ketogenic diet, but of course, we need to a well-formulated energy-conservative metabolic kidney diet protocol that does not put more pressure on the compromised kidney. Do not forget that kidney will begin to join the liver in glyconeogenesis and produce 40% of glucose synthesized in the body. The ability of kidney to use beta-hydroxybutyrate increase the availability of energy and ATP needed to process and reabsorb and secrete. Does the ketogenic diet or does going in starvation do really benefit the kidney? This is the main question. If a patient do low carbohydrate diet, does being in ketosis itself help the kidney to regenerate? At first, ACE activity is reduced. By going into ketosis, ACE activity is reduced during starvation, which reduces blood pressure and enhance vasodilation. This is the first. Second, reducing glucose ingestion reduced insulin and thyroxine, which will reduce the action of angiotensinogen liver production. Blood pressure reduction during fasting may result because of low TSH. Liver health will be better as we're going into ketosis and fasting. The liver will burn the fat inside and the insulin resistance in the fat will reduce. The kidney is very powerful in producing glucose by glyconeogenesis and can synthesize glucose. So by the introduction of glyconeogenesis in the kidney, more energy is delivered by the kidney itself, as well as the beta hydroxybutyrate, when it is burned inside the kidney thrive, and the inflammation is reduced, as well as the amount of beta hydroxybutyrate in the kidney, which when the person is in ketosis, is 20 times more. When we have a diabetic who has high level of sugar, when we have a diabetic with a high level of sugar, this diabetic, let's say he has 180 milligrams per deciliter, which is almost twice the blood sugar, the normal blood sugar. So when we reduce the amount of sugar in his blood, whatever by keto or by keto and medication, the blood sugar will reduce the sugar will reduce in his blood. So the sodium pumps, the glucose sodium pumps will reduce absorptions because the amount of sugar entering the kidney is less. Each gram of sugar will accumulate or absorb 3 grams or 4 grams of water inside the cortex. Each gram of salt will grab 6 grams of water. So by reducing only glucose and sodium, the hypertension in the kidney will be reduced because of the reduction of amount of salt and glucose. Neither we are speaking about renin and angiotensin pathway. The same effect happens when we use the SGL2 inhibitor, LT inhibitor. It's reduce the amount of energy in the kidney that the body have to go into starvation mode. That's why there's a lot of publications about the positive impact of CGL2 drugs for blood glucose normalization in kidney. After decreasing the absolute, getting into ketosis and decreasing the hypertension in the kidney, it seems that podocyte can regenerate again. Beta hydroxybutyrate increase the production of the kidney against beta hydroxybutyrate increase the protection of kidney against different toxins. As some experiments have shown that even paraquat, has this effect on kidney when it's consumed during ketosis. So what should the diabetic with kidney disease eat to heal? The diet should protect the kidney from kidney stones formation, reduce energy demand in the kidney, as well as reduce hypertension and renal cortex. We have to protect the kidney from kidney stones. We have to reduce the energy consumption in the kidney, and we have to reduce the hypertension in the renal cortex, which is the main cause of the disease itself. A diet low in sugar that mimic starvation will reduce the effect of ACE production, so the hypertension will reduce. While consuming low protein will reduce the energy needed to get rid of urea and ammonia. Low phosphate diet, we have to do low potassium diet, as well as we have to reduce the purine and eliminate fructose. This will prevent increase in uric acid and kidney stones from uric acid. So when we are speaking about what is the micronutrients we can do with such a diet. At first, carbohydrates should be restricted to not more than 5%. Usually in my practice, I give about 10 to 12, even to 15% of calorie consumption per day. But when I deal with a patient with CKD and I want to help him, I will reduce carbohydrate even more to 5%. The restriction should control the blood sugar. We will not have any benefit by restricting blood sugar, sugar ingestion, if the blood sugar is over 80. Yani if the patient have high blood sugar, we have to give him medication that help to lower blood sugar. I think CGLT inhibitors is one of the best, but the problem with this drug, it mimics starvation, mimics ketosis. So we have to measure his blood ketones to prevent ketoacidosis. What about fat? Fat, we can do about 80 to 85% of kilocalories from fat. But the fat should be natural fat, like it should be ghee, animal fat, olive oils, non-refined coconut oil, and eliminate all oils, vegetable oils that is refined. Protein. According to recommendations, protein for normal individuals should be not less than 0.8 gram per kilogram. In regular cases of CKD, chronic kidney disease, it's suggested that we should not reduce the protein unless he reached phase 3 or 4. So in my practice, I reduce the protein between 0.6 to 0.8 gram per kilogram of normal body weight. So if he is 175 tall, okay, or his height is 175, I will give him about 60 or 55 grams of protein daily in order to reach 0.6 to 0.7 gram per day. What about phosphorus? The most difficult issue in designing the CKD diet is to control the phosphorus. It's easy to control the protein. It's easy to control the potassium. It's easy to control the carbohydrate. But for phosphorus, it's the most difficult. The kidney usually secrete about 750 milligrams of phosphorus daily. So it's by recommendation, we should not increase the consumption daily about more than 800 milligrams. So phosphorus will be tied to the amount of reduction in the kidney secretion of phosphorus. A normal kidney can secrete 800 milligrams per day, while a patient with CKD can secrete 650 milligrams per day. By the way, bread has a high level of phosphorus, so it's easy to switch from bread to meat. Potassium, we restrict leafy greens. Not restricted, we have control about it. We reduce the potassium intake to 2,000 milligrams per day. Can we reverse kidney disease? According to our practice, by this protocol, it's positive. Not stop progression, but also reverse the nephropathy and increase the GFR to patients. We have patients that have reduced from stage 5 to stage 1. We have patients that have reduced 60 years old, reduced from stage 5 to stage 3. Our protocols aim to support the relief of the kidney by reducing ATP energy demand, as well as reducing glomerulus mechanical tension within the reduction of cortex static pressure. All our patients were put in low potassium, low phosphorus, and low protein, low purine, very low carb, very high fat diet. Yes, we can if the diabetes is managed properly and the kidney cortex pressure, static pressure is reduced. Yes, we can if the ATP renal production capacity exceeds the demand by reducing anything that the kidney has to bit of effort on secreting and reabsorption. Yes, we can if the blood pressure of the patient kept below 125/80. Yes, we can if the patient decide to heal and commit with the program without relapse. This is some of our data. The first one is the highest mark is 6.25. A patient, 21 years old. She has an acute kidney injury caused by taking painkillers. So she was put in the hospital with a creatinine of 6.25. After she have left the hospital, she began directly with us and put in that the same protocol I have explained in the lecture. Within 6.5 weeks, she returned to 0.67 creatinine level. Another patient have 5.61 creatinine level. He is 61 years old. He uses about 40 units of insulin. Of course, he's a diabetic. We managed to put him in the diet and reduce the insulin that he has to 10 units only, 1/4 of the previous insulin injection dose. Within 11 weeks, his creatinine was reduced to 4.1. Yesterday he called me, his new result appears, he's 3.7 now. This lady, 45 years old, within 4 weeks, she dropped from 3.14 to 3.1. Unfortunately, this patient did not have the similar results as all. After that, she has relapse in her health, stress, and her blood pressure continued to rise. We cannot control her blood pressure. That prevents this lady from healing. The other results here, we can see that 1.6 within 10 weeks he reduced to 0.7. This patient from 1.03 to 0.75. So the biggest marker here in this protocol, we have to control the blood pressure to prevent further damage. We have to control blood sugar to help the pressure to get down. We have to if the patient cannot control his blood pressure and blood sugar, we have to do medication with the help of his doctors in order to control his symptoms. Thank you for listening. And for further cooperation in the clinical trial management, we are always open to